Geriatric, Dr. Allison and Susan for your work in coordinating this effort. I think this is a really a great platform, and I'm really excited to be here. I want to recognize my co-author, Dr. Kirsten Palambaro, who collaborated with me on this study and who really added great contributions. And without her, this project would not have been completed. So I really recognize her work and thank her for that. I also want to recognize and thank my wonderful colleagues of 2017 at the Life Care Center of Kirkland, who took time out of their busy schedules to work on this project with me and help collect data. And again, without you, this project could not have been completed. So thanks so much for that teamwork and effort. I am so enthused to have this opportunity to talk about the modified 30-second sit-to-stand test. The reason is this in a nutshell. We need good tests for lower functioning older adults. That was definitely my motivation in working on this research and wanting to do this study. And it's my hope that this work really contributes to that effort of having tests that work for some of our lower functioning older adult population. So when we think about sit to stand, of course, that's just, at the bedrock of so many of our treatments. And in many of our settings, we see older adults having difficulties with this in hospitals, skilled nursing, home health, even outpatient. This is the focus of a lot of our interventions. And we have great tools to test sit to stand. We have the 5-time sit to stand test. We have the 30-second sit to stand test. We have lots of good study behind those tools as well. So we have norms, we have cutoff scores, we have minimal detectable change values, and a lot of great information on those excellent tests. However, how well do they work across the board for our older adult population? So let's take a look. A couple studies out there looked at how well do people do with these tests. And 2 studies that I've cited here one showed 46%, one showed 81% of hospitalized older adults were unable to complete 1 repetition without hand support. Bohannon did a study in home care looking at older adults there and found over 57%, well over half, could not complete the 5-time sit-to-stand test. And a fair percentage of those couldn't even complete 1 repetition of the test. Okay, so what happens then in the clinic? How do we measure sit to stand? Because we know it's a valuable thing to treat, to address with our patients, and we know we need to. So what happens is that we see our patients, and they're using hand support, right? They can't do it without it, many of our patients. So the test is commonly modified. And so I see this a lot. I've seen this in a lot of different settings. Therapists use the 30-second sit-to-stand test or the 5-time sit-to-stand test and say with hand support. The problem is, this is done in all kinds of ways. I've seen, 2 hands pushing from the chair, a hand on the chair, a hand on the walker, right? Or using another type of assistive device. We don't know how much they're using it. I've seen pulling up from a bar, right? And all those are completely different tasks. And then the problem is we don't have any of the data behind those tests. They're not standardized tests. We can't use normative data. We can't use cutoff scores. We can't use minimal detectable change. So how well are we really measuring our patients if we are modifying this not in a standardized way? So we can see the need for standardizing this type of test so our older adults who have trouble can participate. And there hasn't been that much study on this so far. So all of this was good motivation for me to delve into this and do some work in studying a modified sit-to-stand test. So there have been a couple studies published previous to our study, and they found one 2016, 2017, so fairly recent, Leber's study showed that the test had good test-retest reliability, and it showed a moderate correlation with the timed up and go. So that's good information. Applebaum did a study looking at fall risk and found that there was a significant correlation with the test when looking at number of falls occurring in 1 year. Okay, so in other words, fewer repetitions on the sit-to-stand looked like it correlated with higher risk of falls, and vice versa. So this was some background study that we had on the test. So what did we seek to do in our study? We wanted to look more at reliability, look at both inter-rater and test-retest intra-rater reliability to know, can this test be used reliably between clinicians? Because that's how we function all the time in the clinic, and it's definitely important. We wanted to look at convergent validity and predictive validity, looking at the relationship of the modified sit-to-stand test with balance, looking at its relationship to lower leg strength, and then looking at its relationship to ADL function, general ADL. And we also wanted to see about calculating a minimal detectable change, so we would know what represented change beyond error, testing error. So we'll talk a little bit about how the study worked. We had 2 phases. The first phase was our reliability portion. So for this phase, we filmed 7 participants doing the test, the modified 30-second sit-to-stand, and then we had 10 raters. They were both PT and PTA there at the SNF. And they were trained on the modified 30-second sit-to-stand test. We had a meeting and orientation and training on the test. The raters scored the film test twice, and they were scored 3 weeks apart. So that was the way we looked at our reliability. Phase 2 was exploring the validity. So for this phase, we screened all referrals to the skilled nursing facility, both inpatient and outpatient. We did get a few, primarily inpatient, but we did get a few outpatient referrals, and we also included them if they were willing. We screened them for eligibility. We had 33 participants that agreed. And then data was collected on these outcome measures, I'll talk about in just a second, by both PT and PTA. This study was performed in Washington State, and in our state, PTAs are allowed in their Practice Act to perform functional tests and do that all the time, routinely. So that's how data was collected. For our design in phase 2, the project assistants, or the data collectors, the PTs and PTAs, were trained. We had sessions to make sure that we were all performing the tests accurately and in a uniform manner. We then collected data on the measures at both admit and then discharge. Measures we collected were the modified 30-second sit-to-stand. We also collected the Berg Balance Scale. We tested knee extensor strength, and we tested it with handheld dynamometry. And then we also collected modified Barthel Index scores. So those were also routinely collected as part of the data set at the skilled nursing facility. So we obtained those scores that were scored by OT by chart review. Now here is what I feel is a really important part of this study and an important contribution. We really spelled out the protocol that we were going to use for the modified sit-to-stand test. So we used a standard height chair, that's nothing different. We used a chair with armrests, so that's a little bit different than other tests. So they weren't pushing from the seat, they were pushing from an armrest. The participant was seated at the edge of the chair, hands on the armrest, ready to go. And they started performing sit-to-stands when the tester said go. Now here's what was important, I felt. We decided to standardize it and not make sure that they did not lean back on the chair with their legs, because you've seen in the clinic how people compensate for weakness and difficulty. Oftentimes they'll brace themselves on the support surface or the chair. So we did not allow them to do any of that. And we also required that they must let go of the armrests and bring their arms to the midline of the body momentarily in between repetitions. So they were required to balance on their own without hand support momentarily in between repetitions. The reason we decided this, how can you really standardize how much they might use an assistive device if they were to use one? I just felt the best way to go forward with standardizing this test would be to eliminate those supports. So then we counted the number of stands in 30 seconds that were performed. Okay, here was our inclusion and exclusion criteria. Participants were included if they were 65 years or older, and they were unable to rise one time without hand support. So if they could rise one time without hand support, they were not an appropriate candidate for this test. They could participate in the standard 30 seconds at the stand test. So we excluded them if they could do that. Other exclusion criteria: dementia, any restricted weight bearing, hip precautions, any pain that was exacerbated by sit to stand, behavioral issues, inability to understand verbal directions or understand English were our exclusion criteria. Characteristics of our population. Average age, 85 years, average 2 primary diagnoses, and 5 to 7 comorbidities. So this is the population that us clinicians that we see out there referred in our settings where they're really having struggles with their mobility. They were complex patients. On purpose, we did not choose certain diagnoses. We wanted to get a general population to reflect how the test worked with that general population. The vast majority were inpatients. I think we had 2 or perhaps 3 outpatients. They were also at a lower level, as you can see from the data in their test scores. Okay, our results. What we found for reliability, inter-rater reliability was moderately good, ICC of 0.737. The retest intra-rater reliability was excellent. So anyhow, good reliability to go forward and feel confident using this test between raters and for retesting with the same rater. For our validity findings, we found moderate concurrent validity with the Berg Balance Scale. We found moderate to good concurrent validity with the Modified Barthel Index. These were measured both at admit and discharge again. We found moderate predictive validity for higher Berg Balance scores at discharge. So in other words, the initial modified 30 seconds at the stand test explained up to 1/3 of the gains in the Berg Balance score at discharge. We did not find a relationship with knee extensor strength, and we looked at both strength values and strength adjusted to body weight. So that was a little bit surprising to me. I thought we would see a relationship there to knee extensor strength, as has been displayed in other work with sit-to-stand testing. What we found for minimal detectable change, it was calculated to be 0.7, indicating that gaining 1 repetition, a change of 1 repetition is change beyond error for this test. And I think, just interestingly, as a side note, I think the fact that 1 repetition is considered change beyond error can be considered a significant change has to do with how the test was standardized. It had relatively high demands in terms of what we required for the sit-to-stand test. I love this with the feasibility, what we found, 73% of participants were able to do at least 1 repetition at initial examination, and 82% were able to do at least 1 rep on discharge. So they could be tested. And that was really a goal here in working on looking at our standardized measures and looking for lower level measures for our population. So to summarize, the modified 30 seconds sit-to-stand test, we have information now on its reliability and its validity And it looks good in terms of moving forward using this test, knowing more about what we're measuring, knowing more about its relationship to both function and to balance. We have developed here a testing protocol that's really well spelled out and well defined for modified sit-to-stand testing. So if this test and tool can be implemented widely in clinical settings or even widely amongst therapists in your setting, I think we can have a lot more confidence on getting a good assessment at their initial examination, and then knowing that we're reflecting whatever progress they may be making accurately if we're testing with this defined protocol among raters. We can feel confident in having a tool that's more feasible. We can pull another tool in our toolbox that's got good feasibility that we can use with our older adults who are working at a lower level. We have a minimal detectable change value to draw from, so that helps us interpret our findings in the test, know that we're testing our whatever results we have might be beyond testing error. And we know that improvement in the test can indicate improving balance and improving function. And so I think those are really important things for clinical application from this study. Hopefully it's something that you can apply in your setting even tomorrow if you run across a patient who can't do a standardized test. We don't have the ability to say right now from the findings that we have thus far that this test indicates improving strength, because we did not see that correlation with knee extensor strength. However, that could be a great avenue for future study. So looking at the future and thinking about future study for this test, I do think looking at correlation studies, one idea, as I just mentioned with strength, might be looking at how does the modified 30 seconds at the stand test correlate with a more global strength measure like a hand grip, or maybe multiple strength measures that might include upper extremity strength. Because I think certainly we might feel that it is indicating improving strength in our patient, but we don't have that information yet. I think correlation with another well-studied performance measure like gait speed could be very useful in learning more about the modified 30 seconds at the stand test. Looking more in depth at fall prediction, we did have the one study that I mentioned that looked at fall prediction and the relationship to the timed up and go. I think it would be interesting to collect data on injurious falls. We know that all falls are important, but of course, injurious ones are extremely important for us to target our interventions towards avoiding. And if we could find a relationship, perhaps a cutoff score, that could be very valuable in future study. And I think it would also be worthwhile and very useful to look at studying reference values / normative data for this test. Now we know it's not really normal to require hand support to rise. Normally, we have data that show older adults should be able to rise without hand support in a healthy population. However, certain subsets of the population might look very different, and I think establishing reference values would help us with interpreting our data, goal setting, making clinical decisions. So that's our study, a bit of a summary, and I look forward to hearing from Suzanne and hearing your questions.
Thank you, Linda. We have Suzanne, if you can share your screen. All right, thank you so much, David.
So I wanted to start by thanking the APTA Geriatrics section for allowing me the opportunity to participate in this journal club. And a special thank you to Linda for choosing me to partner with her in performing the case study portion of this journal club. It's been such a wonderful opportunity. And of course, thank you to all of the participants who chose to join us this evening. So I wanted to talk to you about a case where I was inspired to use a modified 30-second sit-to-stand test as an assessment of functional mobility and a way to measure progress over time after reading the article published by Linda McAllister and Kirsten Palambaro. I would like to start by introducing you to this lovely woman that I had the opportunity to work with. Mrs. Nackett is a 91-year-old female who was referred to see me in home-based outpatient for management of bilateral knee pain as a result of osteoarthritis in both knees. Mrs. Nackett has suffered from pain related to the osteoarthritis in her knees for numerous years, but she noticed a worsening in her symptoms following a fall 1 year ago that resulted in a right hip fracture that was managed with ORIF. Mrs. Nackett reported a worsening in the symptoms associated with the osteoarthritis in her knees following a period of immobility which resulted from the hip fracture. Mrs. Nackett reports that functionally, she has significant difficulty rising from a seated position across multiple surfaces. A little bit more about Mrs. Nackett. She has a past medical history significant for hypertension, lung cancer, incontinence, age-related vision and hearing loss, and 2 reported falls in the past year, one of which resulted in the hip fracture. Here is also a list of her current medication, which includes metoprolol for her blood pressure, simvastatin for her cholesterol, hydrochlorothiazide for her blood pressure, and meloxicam as needed for her bilateral knee pain. As far as her home environment, Mrs. Nackett is widowed and lives alone in a multi-story home with 4 steps to enter. She sleeps on the first level in her TV room and has access to a half bathroom. She is unable to access her bedroom and full bathroom on the 2nd level at this time. She relies on a network of extended family, neighbors, and friends for assistance with IADLs and transportation. She ambulates with the assistance of a rolling walker and is generally sedentary following her fall with hip fracture 1 year ago. Her personal goal would be able to rise from a chair without difficulty and pain in her knees and to walk longer distances with better posture and less fatigue. On this slide, I have her objective data listed. Due to time restraints, I won't be going through every finding, but I will pick out some of the more pertinent data to review. Her balance confidence was measured with the use of the ABC scale, and she scored 15.6%, which indicates a low level of functioning in the older adult population. She also presents with some postural impairments and a thoracic kyphosis, significant forward head posture, and bilateral knee genu-valgum. She presents with poor flexibility and some significant strength deficits, as seen listed here for your reference. Continuing on with her objective findings, her self-selected walking speed of 0.7 meters per second classifies her as a limited community ambulator and as someone who would benefit from intervention to reduce fall risk, according to the white paper published by Fritz and Lusardi. Her timed up and go score of 28.27 seconds indicates a risk for falling when compared to the cutoff score of 13.5 seconds. Her Berg Balance Scale score is 22 out of 56, which is less than the cutoff score of 45, which indicates a fall risk. A score of less than 40 on the Berg Balance Scale has been determined to be associated with almost a 100% fall risk, according to Shumway and Cook. On the modified 30-second sit-to-stand test, she was able to perform 4 repetitions of the sit-to-stand transfer on initial evaluation. Mrs. Nackett received home-based outpatient therapy services 2 times a week with a focus on strength training and flexibility for the lower extremities, postural exercises, transfer training from different height surfaces, and balance and gait activities. A home exercise program was also established with the same focus as treatment. I was able to use the modified 30-second sit-to-stand test as a guide for treatment approach to the sit-to-stand transfer. In assessing the areas of difficulty she had in performing the assessment, I was able to then target the areas in which she needed to make improvements. For example, we worked on anterior weight shifting to bring her center of mass forward over her base of support, and we focused on eccentric control work during the descent component of the stand-to-sit transfer. This slide depicts her progress at the 3-week mark. I'm not going to spend too much time here, but just as a summary of her progress, she had notable improvement in her balance confidence score as measured by the ABC, improvement in her reported level of pain, improvement in her level of flexibility, and overall improvement in her manual muscle testing scores. On this slide, we can see that her self-selected walking speed improved to 0.91 meters per second, which now classifies her as a community ambulator, but continues to classify her as someone who would benefit from intervention to reduce fall risk, according to the white paper by Fritz and Lusardi. Her timed up and go score improved from a 28.27 seconds to 22.14 seconds, which is an improvement of 6.13 seconds, which continues to classify her as at risk for falling above that 13.5 second cutoff score. With the timed up and go, there is no established minimal detectable change, or MDC, for the general older adult population to assess change beyond error. We can be confident that she had an improvement on the assessment, but we cannot be confident that the change was beyond error. Her Berg balance score improved from 22 to 26 out of 56, which was a 4-point change at the 3-week mark. The MDC for the Berg scale varies according to the score value. An MDC for a score of 26 on the Berg is 6.3 points. With her improvement of 4 points, we cannot be confident that her change in score was a significant change beyond measurement error. Her modified 30-second sit-to-stand test improved from 4 to 5 repetitions at the 3-week mark. An MDC was established in the article that was just reviewed by Linda and her colleague as 0.70. So here, we can be confident that an increase in 1 repetition is change beyond error. Here on this slide are some images of Mrs. Naked performing her 30-second sit-to-stand test. Here in the first picture, she is at the initial phase when she has scooted forward in the chair and is ready to push with the use of her arms. In the second picture, she's mid-transfer. And the final image is Mrs. Naked achieving an erect posture as she comes to a full stand, letting go of the armrest as outlined in the procedures for the assessment. As a review, the procedures for the modified 30-second sit-to-stand test are as follows. The chair is placed against the wall to anchor it. The test begins with the participant seated in the middle of the chair with the back straight and feet shoulder width apart. The participant is instructed to place their hands on the armrest. At the signal go, the participant rises to a full stand with the body straight and erect, and then returns to the initial position. The participant is instructed to let go of the armrest and bring the upper extremities to midline of the body when attaining a fully upright standing posture. The participant is instructed to fully sit down between each stand and to stop if the sit-to-stand movement exacerbated pain. Here I have some videos from the initial evaluation and at the 3-week post-intervention mark to demonstrate her progress on the modified 30-second sit-to-stand test. So here she is at her initial evaluation. Oops, oh, hold on, not that one. Technical difficulties. There we go. Okay, this is initial evaluation. Now, I am not a videographer. I think I cut her head off in almost every single video and picture I took of her. So just a disclaimer there. But as you can see, when she comes to from her stand to sit position, her eccentric control of descent is very poor. She lets gravity kind of take over and get her into that sitting position here. So that was initial evaluation. She completed 4 repetitions of the sit to stand. Rewind this one. Okay, and this was 3 weeks later. Now, a little bit of a disclaimer for this video. I had performed her reassessment with all of the tests and measures I had to perform, and I completely forgot to record the assessment when I completed the armrest of the chair when she completed the sit to stand component. So during the reassessment, she had let go of the armrest, but unfortunately for this video, she does hold on. So a little bit of a disclaimer there, but this is her completing the test at the 3-week mark. And as you can see too, when she comes to from her stand to sit position, especially in this repetition, you can see how the control of her descent, her eccentric control has improved significantly. Her power has improved, her speed has increased. And that can be seen by reviewing this assessment. And that's me. Okay. And then one little interesting thing is, she's always telling me that I hear your voice in my sleep, sit gracefully, sit down slowly. She says anytime that she goes to sit in a chair, even when she sits on the toilet, she always hears my voice in her head to sit down slowly. So not many people are proud to hear that, but I was very proud to hear that she hears my voice all of the time. Oh, okay. All right. As far as the assessment of her progress, I mentioned previously that she had an improvement in her modified 30-second sit-to-stand score by 1 repetition, which indicated change beyond measurement error according to the MDC of 0.70 seconds or 0.07 repetitions. Also, according to the article reviewed today, the modified 30-second sit-to-stand test demonstrated moderate concurrent validity with the Berg Balance Scale, illustrating that the assessment captures an aspect of balance as seen when the patient lets go of the armrests in achieving an upright posture. Though it was not a significant change above the established MDC, we did see an improvement in her Berg Balance Scale, correlating to an improvement in her modified 30-second sit-to-stand test, which we would expect as clinicians. Continuing on with her assessment, due to a low level of function, Mrs. Naked was unable to complete a sit-to-stand transfer from a standard height chair without the use of her upper extremities, and as a result would not have been a candidate to receive a score on the traditional 5-time sit-to-stand test or the traditional 30-second sit-to-stand test. In being allowed to use her upper extremities, Mrs. Naked was able to receive a score on the newest standardized outcome measure to allow a standardized measurement of change over time with targeted intervention. Prior to the introduction of this modified version of the sit-to-stand test, like Linda had mentioned, some clinicians, including myself, would use the 30-second sit-to-stand test with the allowance of upper extremities in order to provide an objective value on an outcome measure. Due to the allowance of upper extremity use, it would need to be documented that upper extremities were used, and it would be understood that the values could not be compared to the established values of the 30-second sit-to-stand test. We were unable to measure progress over time for the lower functioning group of adults by allowing use of the upper extremities on this test, but now we could do so with an established and standardized measure that is able to capture these low functioning older adults. In standardizing the measure, we are also given the opportunity to utilize the progress demonstrated on the outcomes of this test as justification for successful and effective intervention and in documenting as such, or as a way to alert us as clinicians that we may need to change our treatment approach in order to demonstrate improvement and progress on this functional task as outlined in this outcome measure. According to the article reviewed today, the modified 30-second sit-to-stand test is a reliable and feasible tool for use in the geriatric population with a lower level of functioning, such as the case with Mrs. Naked. The modified 30-second sit-to-stand test can be used as a tool for targeted intervention based on impairments noted in performance of the assessment, just as with any other outcome measure that we use in our day-to-day practice. That is my case study presentation, and I will now turn the floor back over to Susan. If I could figure it out.
Thank you, Suzanne. So some questions that come through. So this is for Suzanne. A question was, since her main reason for the case study patient, her main reason for referral was knee pain. So the question is, did you address her knee pain, and did her knee pain impact her ability to participate?
Yes, I absolutely did address her knee pain. But as I mentioned before, the reason I had chosen the modified 30-second sit-to-stand test to utilize with her is as a result of the knee pain and significant weakness, one of her biggest complaints was that she had difficulty in performing a sit-to-stand transfer from, her recliner lift chair, from the edge of her bed, from her commode, so different height surfaces, which is why I chose to use a modified 30-second sit-to-stand test with her, because she was unable to complete a repetition without upper extremity support to utilize one of the other tests. And in addressing knee pain, absolutely, I know we didn't focus on intervention with this case study, but I did focus on strengthening of the musculature surrounding the knee, as well as some pain management interventions as well.
What part of the Berg improved?
Uh, I don't have it. I wish I had printed it out with me, but I know the sit to stand, the sit to stand component improved, as well as some of the static as well as the dynamic balance components also improved. I don't have the specific measurements, and I haven't worked with her recently because unfortunately I did have to discharge her to VNA. So I can't recall, and I do apologize for that. The exact items.
Okay. So this question is for Dr. McAllister. Were the patients allowed to use armrests on the descent back into the chair?
Yes. So yes, they reach back for the armrest to lower themselves.
Okay. So another question that follows is, do the arms stay at the person's side or do they move to the in front to be at midline?
So what I meant by midline was in this plane. So they just bring their arms to their side, basically. And that's what's required. And I think, yeah, we saw that in the video too.
Yeah, yeah. Are there established norms? And another question that follows is, since the modified sit-to-stand test is not a standardized outcome measure, can we set a goal for it? Or can we only use it in our assessment and not use it as a goal?
So regarding norms, that is a suggestion for a future study. And I can say that future research is in a development phase right now. I think there's going to be more research coming out on this test, I have a feeling. Yes, so we don't have established norms or reference values at this time, but I hope that we will. And then let's see, can we use, so this says modified sit-to-stand is not a standardized outcome measure. So I'd say it's become one. It's a standardized outcome measure with reliability and validity, minimal detectable change values. So yes, you can certainly use it for assessments. I would love it to be used for goal setting as well.
And like Suzanne said, like to document that they use the armrests as in the documentation.
So yeah, we can document modified 30-second sit-to-stand test. This is now in the literature, you know, as a standardized tool, and it's defined. So we don't really have to spell out the definition, I don't think. But that can, you know, maybe it's helpful to write with hand support just to get the word out there, or for other, you know, communication amongst ourselves until this is really more widely known.
Some questions had come in advance. What was the cutoff score for the test in the study?
The cutoff score for the test. So in our study, in this study that we did?
Yeah, modified 30-second stare sit-to-stand used for determination of the MDC.
Okay, so for the MDC, we did not have a cutoff score in our calculations. I know that can be a way of calculating minimal detectable change. That was not in our calculation. So we have the value of the 0.7 repetitions, but we don't have a cutoff score.
Okay. The Barthel Index and Berg Balance Scale have components of transfers. Hence, if sit-to-stand test was to increase these scales, and FOM would show better scores, but would it be clinically significant?
So I think this is asking, would improvements on the modified sit-to-stand test, they will then be reflected in improvements in the modified Barthel Index and the Berg Balance Scale. And I think the question is that clinically significant, or how much would we see of a change in those other tests with improvements in the modified 30-second sit-to-stand? So that was not part of the calculations of our study. That could be a very interesting question for future research, to see how does a change, you know, a value of change in the modified 30-second relate to changes in other measurements, and how much those would be. But yes, not part of our study.
Someone is mute your microphone. There you go. I muted
I
them.
know the test is very exciting, so I'm glad to have a good reaction. Okay.
Another question was, is it possible that the knee extensor strength did not correlate as patients were using a combination of upper extremity and lower extremities to push up? In my experience, older folks tend to rely on upper extremity to pull up to stand.
Yeah, absolutely. I think there's definitely interplay with upper and lower extremities when you change the task like that. And so yes, for sure. I think that affected what we saw in terms of, we only tested one muscle group, the knee extensors. And so, yes, like I said, I think testing more muscle groups or perhaps a global strength measure would show us something different.
I think this question is for Suzanne. Did you measure tricep strength before and after? Or maybe it's for both of you guys.
I did measure, I did not measure tricep strength, not with a dynamometer. I did a general manual muscle test, and she was at least a 3 out of 5, probably at least a 4. I don't have that information with me tonight, but I didn't focus on that and to give you a valid answer.
Thank you. As you mentioned, it says, just to confirm that the subjects were inpatient. So results may differ in other settings like home health patients, may be a different research.
Sure. I mean, it would be great to collect more information on how other groups and populations respond and to the test, or what their values look like. Yes. Let's see.
Dr. McAllister, this question is for you. If an older adult cannot get the feet behind the knees because of limited ankle or knee range of motion, they are at quite a bit of a mechanical disadvantage for sit to stand. And number 2, inability to anteriorly tilt the pelvis, common in persons with structural kyphosis, is also a biomechanical disadvantage. Pain is a major issue. Use of upper extremities to offload the weight from the lower extremities to reduce the pain. I would love to see a multiple regression study that included not only lower extremity strength, but lower extremity range of motion, spine and pelvis range of motion, and pain during the task as covariates. What do you think?
I think that would be great. I think all of these things can, definitely affect sit to stand ability. So it sounds like you've halfway written your proposal here for a study. Yes, I mean, those are all barriers to why, barriers to sit to stand for our older adult population. And lots of other factors besides lower extremity strength come into play. So agreed.
Can we assume that improved scores on the test indicate improved lower extremity strength? Does it speak to your endurance at all, in your opinion?
So I think, there can be an endurance component I know that the repeated sit to stand model, like a 30-second sit to stand test, there's discussion of that being more an endurance test, right? Because you have lots of repetitions. So I don't think we can assume anything until we study it, right? Until we know more. So endurance could definitely be a component. I guess what strikes me though with this population in terms of frailty, et cetera, of how much that is related to strength deficits and impairments. So that was my first line of thinking, and looking at a muscle group that that had shown relationship to sit-to-stand tests in other studies.
How, Dr. McAllister, how best would you interpret the test results without established norms in a clinical setting?
So yes, we don't have norms. I mean, I think there's lots of ways to use this test. We can get a good baseline. We can strive for achieving improvement beyond error, right? One repetition or more. I think that we can work towards rising without hand support, right? Graduating them to another level of test where we do have, you know, other things to interpret with some of the more established tests. Another thought is Applebaum's study, which I briefly mentioned at the beginning, does have some information on relationship to falls. And they did use a cutoff score of 7 repetitions. That cutoff score had very high sensitivity but low specificity. So it's not an ideal cutoff score, but it did show that there were fewer falls. It was associated with fewer falls with 7 or more repetitions. So given the limited information we have, those are some things to shoot for that are a lot better than just shooting in the dark, right? In terms of interpreting and goal setting.
Do you think we are getting too fixated on the impairments improvements, but rather this is a test for task performance rather than strength, range of motion, and endurance?
So that this is a test looking at performance of a functional task. And that's why we need a test like this versus just looking at strength values or range of motion impairments. I mean, I think it's important to look at all of it, really. As in the comment previously, there's reasons why our older adults have difficulty with this, and they can be complex, or they're not all the same. And so we have to look in detail, I think, at specific impairments, but I think there is a lot of value to looking at good old function, right? I mean, this is the basis. Sit to stand is at the basis of older adults' independence, really, in many, many ways.
Someone just said that maybe associating this test with the RPE values would help with documentation regarding improvements.
Sure, good suggestion. Pull in another value that gives us some information.
Looks like I just want to say this is really exciting to see and to now have an MDC for clinical use. I work in a rural critical access hospital, and all of my patients are generally lower functioning and rely on the use of their upper extremities to stand. It is great to now have a good tool to use with this group of patients. Thanks so much for this information. Can't wait to use it in the clinic.
Great.
Everyone says thank you. Looks like we're winding down now, so any other questions can please go ahead and type them. Otherwise, our next journal club will be Tuesday, January 19th, 2021. And I hope everybody has a great night. Thank you for joining us.
Thank you so much.
Thank you both.
Thank you. Thank you.
Looks like all the questions are finished. So.
Yeah.
Right. Thank you, guys.
Thank you.
Nice job, Suzanne. Thank you so much, Susan, for
Thank you,
coordinating.
Suzanne. You're welcome.
Thank you all
Good
so
night.
much. This was great. Thank you.
Thank you.
Thanks, everybody, for participating.
Yes.